Now we are start our new topic today, that is endocrinology. Endocrinology. First we will straight away move on to hormone actions. That is hormone actions, in which we have GPCR mechanism. What type of GPCR mechanism would be occurring in which? So first we go on to GQ. Now GQ, it can be learned by the mnemonic, that is have one M&M chocolate. So you M&M is a chocolate with wine, gonads, oxytocin, tachy. So for wine, you will remember that this is associated with gastrin hormone. Gonads is associated with GnRH, and oxytocin associated with oxytocin is in itself, and tachy is TRH. So what is the second messenger in this? Second messenger in this is IP3 and DAG. So how to remember? See, we have a Gaurav Kapoor as a cricket representative. So what he does, he takes parts in IPL. So IPL and Gaurav Kapoor. So you can mix it up and you get the desired thing. So GQ involves GQ protein, is for have one and m got have one chocolate got, and with the wine, gonads, oxytocin, tachy. Next is G protein, GS, alpha subunit. Alpha subunit is being stimulated by it. So what I would say, you don't remember, and there is a mnemonic that flat champ chug. Flat champ chug. But I would say you don't remember this one because it is really lengthy. Remember the other ones, and if question come, then see, GS is going to be common because GS is stimulatory. Ultimately, endocrine system, majority would be stimulating others so that there can be desired effect. So avoid learning it, but for the sake of completion, I am going to write what each thing means. Now we move on to the G protein. Now inhibitory G protein, that is alpha subunit, in which you have MAD2 and in which cyclic AMP is there. So for MAD2, remember that M2 alpha 2 D2, M2 alpha 2 D2, and this cyclic AMP is reduced. So you can recover written A1. So M2 alpha 2 D2. Just a recall question. Where was M1 and M3? Where was it? So it was in GQ. Therefore, we had both M and M, and then we had GOT. Now, GOT is what associated with GOT, GnRH, oxytocin, and tachy, that is thyroid releasing hormone. So M&M, GOT, wine, fine. Wine, we can remember gastrin of from GOT. We can remember gonads, oxytocins, and TRH. So try to do active recall, and you will remember it. And also, there is one thing more in addition that you would not be seeing in the notes is A1 cover Hindustan Times 3, that is 5-HT3 receptor is also by GI. So it is now the receptor guanylyl cyclase, it is responsible for ban, that is BNP, ANP, and nitrogen. Ban means you are banning something, you are not allowing something, and when you are not allowing something, so what you are wanting? You are wanting that everything would be excreted from the body, and you would give no signal to it. So what is that? That is brain natriuretic peptide, atyl natriuretic peptide. They are responsible for excreting the sodium out of the body. I will. The steroids have intracytoplasmic, whereas rest is the prep TV have intranuclear. So how will you remember? See, insulin pipe. Although you would have learned this mnemonic that insulin pipe is there, that but it would be really difficult to expand if you don't understand the meaning of pipe here, that they are working similarly to insulin, and as insulin is responsible in stimulating the growth like insulin growth factor, so all others will also be acting as growth factors. So remember, P is platelet derived growth factor, I is insulin like growth factor, F is fibroblast growth factor, E is epidermal growth factor. So everything is with growth factor. So again, remember that piglet is using Jack-Stack pathway. In Jack-Stack pathway, the initial pig is prolactin and growth hormone, and the next two is, remember that it's a little bit off track discussion, but remember that what do piglet do? Piglets, how are piglet produced? Now piglets are produced because there is lot of sexual interaction going on between the pigs. So what will happen in that? See, they will have a lot of prolactin secretion and growth hormone, that is understood, because they are piglets, they are small. But how they are produced, you have to remember this. So remember that that it is acting on bone and it is stimulating all the three cell lines, that is GM-CSF, erythropoietin, thrombopoietin. So these are the things that it is stimulating. It is stimulating the blood production. You can remember this is why they for piglet to reproduce, they would need erection. Now if they need erection, then how they can produce? They can produce by having excess of blood, and that will be through Jack-Stack pathway. Now also remember that pigs are fat, so leptin hormone will also be secreted. So by this you can remember the whole of piglet, because if you don't go through this story, I can bet that in exam you would be intermixing L for something else, G for something else. And also remember that in which one what is functioning, that is uh, stat map kinase is associated with uh, JK receptors. How will you remember? See, JK is a JNK is a state. Now, when JNK is a state, so in state, stat would come. You would require a map to move around. So it will be JAG-STAT map kinase. And also remember that in tyrosine kinase there is also map kinase, because if you are having tire, then you will want to move it around the city or move it around the state, and so therefore what you will require maps to move around. So remember that tyrosine kinase is also have a secondary messenger as map kinase. Now we move on to the next map kinase, that is serine kinase. Now serine kinase, this would be not be in your notes because this has not been covered. Now remember serine kinase. So now serine kinase, he is mad, is mad. Now if I put a question in front of you that phospholipase C acts via, well, will it be GS, GI, GQ, GO? Now remember, what is phospholipase C? Phospholipase C is something that converts phospholipid IP3 and DAG. That is that it would be acted upon by phospholipase C. So let us recall what is the function of GSQ. How does GS function? GS is stimulatory. So what will it do? It will be increasing the cyclic AMP level by activating the adenyl cyclase. What will be GI doing? GI would be deactivating the adenyl cyclase. It will deactivate the adenyl cyclase, and therefore there would be reduced cyclic AMP. And also remember that in here there would be opening of the potassium channel. Potassium channel would be opened by GI, whereas calcium channel would be opened by the G stimulatory. Now G naught causes channel inhibition. So we are left with GQ. So correct answer is GQ. How? Recall GQ was Gaurav Kapoor. So what he was doing? Remember that we were having IPL plus tag and that is the product of this. So GQ would be the answer. That is the C option. Now we move towards the diabetes mellitus screening. Now see, in diabetes mellitus screening, we will follow certain parameters like HbA1c. If it is greater than 6.5, then it is diabetes mellitus. If it is less than 5.7, it is a normal. And if there is the value lies between the 5.7 and 6.5, then it is the impaired glucose tolerance. Now we move towards the fasting blood sugar. If it is less than 100, that is normal. If it is greater than 126, that is diabetes mellitus. And if it is in between, then it is impaired glucose tolerance. And from the same way we comes to when see random blood sugar. In random blood sugar, greater than 200 is diabetes, less than 140 is normal, and IGT, impaired glucose tolerance, lies in between 140 and 200. Now we move towards the OGTT, and same thing will happen in oral glucose tolerance test. In that, there would be 75 gram of glucose that would be given, and that would result in absorption. Now we move towards the next, that is metabolic syndrome. Now remember, in metabolic syndrome, what you can do, first you can have central obesity, that is like greater than 102 centimeter in men and greater than 88 centimeter in female. Second criteria is triglycerides greater than 150. So now just recall the criteria of metabolic syndrome. What are the criteria of metabolic syndrome? If you had done your notes, then you would have been recalling it. See, in metabolic syndrome, there would be central obesity. Now, in central obesity, what we will have to remember, that in central obesity, the hip size would be greater than 102 centimeter in male and more than 88 centimeter in female. Now we move towards the triglyceride, that would be greater than 150 milligram per deciliter. And then afterwards we move towards high density lipoprotein, that would be less than 50 in females and less than 40 in males. And lastly, the hypertension. Now hypertension, what would be the blood pressure criteria? That would be 130 by 85. And then there would be fasting glucose would be greater than 100. So fasting glucose would be greater than 100. This is the thing that you can forget a lot, because if someone asks you that what is happening in metabolic syndrome, so our inclination is okay, fine, and fasting blood glucose can be greater than, or when it is greater than 126 and all, then we go. But no, it is beyond. If it crosses the OGTT, I mean, when it comes in the range of oral glucose intolerance, so in that also you can say that it has metabolic syndrome. So just remember that in metabolic syndrome, we are not saying that disease has happened, but they are saying that there are chances of disease happening in future. Because in hypertension also, we have not adopted a very direct criteria that we have, that like 140 by 90. No, we have here 130 by 85. So just recall what you have done, learned, and see the correct value. Here are the correct values that you will have to remember. This will be oral glucose tolerance, that would be impaired glucose tolerance. So everything is lying in between here. BP is also 130 by 85 and triglyceride. So any value, if you are saying, it is just on the outskirts of normal value. If see triglycerides, then 140 is 100 to 150 is considered normal. So 150, if there it is greater than 150, then it is again considered part of metabolic syndrome. So likewise, all the things are there. So just try to not only mug up, but also mug up with understanding, so it will remain long lasting. So many of you will be familiar between difference between type 1 and type 2 diabetes mellitus. So remember that this would be occurring in the young, and it would be in the adults. Habitus, it would be very body would be, habitus mean what would be the shape of the body. So in type 2 mellitus, it is thin, and they are obese here. And in insulin, in type 1 diabetes mellitus, insulin is decreased, whereas the in type 2 mellitus, there is insulin resistance. So ultimately insulin is present there, that is insulin has present, but the ultimately due to insulin resistance it is resulting in hyperglycemia. Now we have B cell mass. Now when you do histopathological examination, so you will find leukocytic infiltration in B cell mass. And for type 2 diabetes mellitus, we will get uh, amyloid deposition. This is islet associated polypeptide deposition in the pancreas. So amyloid deposition is responsible for type 2 diabetes mellitus here. See, and then what is LADA? And latent autoimmune antibodies diabetes. So how you'll remember that what is happening in LADA? So remember that when type 1, just it is the crossing. Now when type 1 diabetes mellitus occurring in the adults, then it is known as LADA. And again, it's just the age group that has migrated. It is occurring adults, and then he would be thin, and there would be decreased insulin levels. There would be insulin dependence that would be there, and beta cell mass would decrease. Now, beta cell mass would decrease, where we were seeing this beta cell mass decreasing in type 3. So, remember that in type 1 diabetes, it is occurring in the adults, but all the rest of the features of the are in the of the young only. So that will see what happens is that in our public health, we have different manifestations of diseases. So fine, they have earlier segregated into type 1 and type 2 diabetes mellitus, but now when they started saying type 1 diabetes mellitus in adults, so they were baffled. So what they should do now? So they now created another new category, that is LADA. So it is as it is saying, that is latent and diabetes. So this would actually have good prognosis. It is only manifested in times of stress, and it will not be manifested in routine. So in there can be insulin dependence, but it would be only in the later part of the life. Now we move on towards the maturity onset diabetes in young. Now we are getting the type 2 diabetes features. Type 2 diabetes features in young. So now we could not name it type 2 diabetes mellitus, so we named it maturity onset diabetes in young. So what is happening? In this, the age group that is affected is 25 years, and greater than 2 generation are affected here. So what happens is that it is autosomal dominant, monogenetic. Most common type is type 3, and the gene that is involved is HNF4 alpha, HNF1 alpha. So now, if I say that this is the type 2 diabetes mellitus in young, so what would be the insulin level here? So insulin level can be decreased and it can be normal. Here there is ambivalent thing. And then beta cell mass. Now beta cell mass may be normal to decreased, and oral hypoglycemic agent would be required because it is a major majority on the see. Oral hypoglycemic agent would not be required early in latent one, but in MOD you will have to require. So remember, in diabetes, there are two types of phenomena seen, that is Dawn phenomena and Somogai phenomena. So in both the phenomena, what we are saying, just for the time being, don't look in the middle part. That is this part. Don't focus on. Now in complication of diabetes mellitus, we see the Dawn phenomena and the Somogai phenomena. In Somogai phenomena, so scientists, for that, out of curiosity, they used to give us a normal diet at the night time, and when they saw in the morning that there was hypoglycemia in both of these patients, so they were perplexed. So what did they say? And they said, okay, fine, now we will monitor the that at night time what is happening. So they at midnight would started measuring the blood glucose level. So in one, the blood glucose level was increased, whereas in others, there was so much insulin secreted there, that is the ultimately blood sugar level dropped. So what happened? Because in somogai you can remember as so much insulin. So from that you can remember that these are the connecting point joints in between. In Dawn phenomena, it was following the smooth curve, but in the somogai phenomena, it went down and then it went up. So ultimately, there was high blood sugar in the morning in both of these conditions. Only remember that in good glycemic control. Now, if you carry on good glycemic control, then what is happening that is microvascular complication can reduce. Now, microvascular complication will reduce, but as per mortality, there would be no change. And what is the most common microvascular complication? You would have seen in the OPD that patient with diabetic neuropathy, diabetic foot are coming. That is because of diabetic neuropathy. And what is the most common type? Since they come many often, if you have seen patients from rural area, they would come and they would have their foot infected in both the parts. So now all the ultra short acting are having SS in between. SSS. You can remember that by lisproaspart glulisine. Now they have peak reaching at 1 hour, and after that it will dip down. So remember what will happen, that there could be postprandial hyperglycemia followed by hypoglycemia because of the short acting one. So if you can learn, then remember all this in sequence, that is lisproaspart glulisine, and then neuroprotamine H down and detimer. So glargine is long acting, NPH and detimer are intermediate acting, and since glargine is long, both glargine and detimer, they are long acting, therefore they will not have no peaks. But one thing remember, that glargine, see if you do if in Hindi doctors often prescribe galara, so will you do galara with acid water? Never. So remember that glargine cannot be mixed with acid. So they will have to, if you can given infusion, they have to given separately. Now what are the side effects of these insulin? Now remember that it can be weight gain, and also there can be hypoglycemia. Why? Because see, remember here we are giving the insulin in its purest form, and insulin when given, it is an anabolic hormone, so obviously it will cause weight gain, and it can cause decrease in potassium because it drives potassium into the cell. And also remember that there can be lipoatrophy at the injection site. Now we have insulin like drugs. Now what happens in these are oral hypoglycemic agents which have particular mechanism of action. So what in the, remember secretagogue, what are, now secretagogue can be divided into three types: mnemonic mess, that is meglitinide, incretins, and sulfonylureas. So incretins use glucagon-like peptide 1 and dipeptyl peptidase 4 inhibitor. Incretins use glucagon-like peptide to stimulate the insulin secretion, but it is the incretins degrade by dipeptyl peptidase 4. So what will happen? Incretins is physiologically increases insulin in response to glucose load. So what happens is that there is glucagon-like peptide that is responsible for insulin secretion, and glucagon-like peptide is degraded by dipeptyl peptidase 4. So anything that is GLP-1 analog will stimulate the insulin secretion, and anything that is inhibiting the degradation of GLP will also increase the insulin secretion. So incretins, by this way, they increase the insulin secretion. One of the important drug of this class is pramlintide. So what happens is that not only what does pramlintide do? Now increases the insulin sensitivity like bigonide. Now with had the third class of drug is reabsorption from kidney, that is SGLT2 inhibitors, and the fourth class of drugs is decreased intestinal absorption, that is alpha glucosidase inhibitor. Now we cover the oral hypoglycemic agents. Now in oral hypoglycemic agent, remember that sulfonylureas and chlorpropamide, these are the first line, and glipizide and glyburide, they are second line. Now what is the mechanism of action? There is potassium ATP channel blocker, and now it will have hypoglycemia as the side effect, and weight gain can occur. And also remember that chlorpropamide is were also used. So remember that in chlorpropamide what happens is that there can be SIADH, cholestatic jaundice, and disulfiram reaction. Now we have bigonides. Now bigonides we have metformin, which stimulates AMP kinase, decreases insulin resistance, lactase disease, weight loss, vitamin B12 deficiency, and maximum reduction in HbA1c. Now remember that sulfonylureas we have discussed, maglitide discussed. Now we move on to the bigonides or metformin. It stimulates the AMP kinase, decreases insulin resistance, lactic acidosis, weight loss, vitamin B12 deficiency, maximum reduction in HbA1c. Remember, you will be confused regarding which one is used for what. So remember that metformin is used in obesity and sulfonylurea is given to thin individual. By most you can remember this, and also remember that metformin. So remember this is a Rajiv Chowk, and here two trains are meeting inside the tunnel. So suppose there are six bogies in the tunnel of each track. So we have B12. So there is B12 deficiency with metformin. And see, remember, because this is metallic, that someone that is going inside the suppose this whole body of a person, so this will cause irritation, will lead to mild diarrhea and tiredness, and also it would be bring abdominal pain in the mother earth. And from here there would be also be trying to throw out. So see, remember, if there is a train inside, it has to either go this way or this way. So metformin causes both. It causes diarrhea as well as nausea, and it acts on mitochondrial respiratory chain. So also remember that because if you have seen that the Raji Chowk area is very much crowded, so lactic acidosis is there a lot of, because oxygen is not available in sufficient amount. Now remember, so it causes hypotensive state, decreased oxygenation. It can be due to lung, heart, liver, renal disease. But inside Raji Chowk, if crowds furious or cement put at both its end, that is furosemide or cimetidine can cause metformin toxicity. Agar if we use furosemide or cimetidine, it can cause metformin toxicity. See, one of the mechanism that is postulated for lactic acidosis is there. It interferes mitochondrial respiratory chain, which results in ultimately increased glycolysis, which ultimately leads to lactic acidosis. Now we move on to the thiazolidinediones is pioglitazone and rosiglitazone. So uh, here it is gila gila. Now when it is gila gila, so what it will do? It will increase the chances of risk of bladder cancer, because your pani PO, it is pani PO. If you are drinking a lot of water, the bladder cancer chances are there. Remember that it is PPAR gamma agonist. Remember PPAR alpha. Now PPAR alpha is of which disease? That is which drug is used? Phenofibromate, phenofibrate. It is for increased triglycerides. Now we have GLP-1 analog and dipeptyl peptidase inhibitor. Just remember the name now, and we have discussed it earlier also. How they are acting, mechanism of action has been already discussed. Now amylin analog, that is pramlintide, it increases satiety. See what I mean in this, amylin peptide that is released from the pancreas and acts on the other part of the body. That is, it acts on brain to reduce glucagon secretion of alpha cells, reduces gastrointestinal motility, decreases absorption of glucose, early feeling of satiety. Now it reduces gastric emptying, decreases absorption of glucose, and it will bring early satiety. Glucagon inhibition is a goal of treatment in both type 1 and 2, that is glucagon inhibited. Now we move on to the this pramlintide. Remember that it is used approved only for type 1 diabetes. It is approved for only type 1 diabetes. Now we have alpha glucoside inhibitors, that is acarbose and miglitol. It reduces intestinal disaccharide absorption. It can cause diarrhea, flatulence, contraindicated in IVD. Now SGLT2 inhibitors, canagliflozin, dapagliflozin, it increases renal glucose excretion. It will cause urinary tract infection, polyuria, and weight loss. One thing you remember that linagliptin is measured metabolized by liver, and dose remains unaltered in renal failure. Therefore, the one thing that you have to remember is that one thing also note that this the glutathione is making wet everything, so bones are also being made wet, therefore it will cause fractures. Now remember that there is a difference between diabetic ketoacidosis and HSS. What is HSS? It is hyperketotic hyperosmolar. Now in this, remember that what is there, that is in this we have blood glucose around 250 to 300 in diabetic ketoacidosis, whereas in HSS it is 500 to 600. In diabetic ketoacidosis there is hagma. Why? Because there are a lot of organ disease. We are saying that diabetic ketoacidosis, as the name itself implies, that new organic acids are being synthesized. When new organic acids are being synthesized, so it will show hagma, whereas HHS would be remain normal. Now ketones are present in DKA, but it is absent in HSS. Because ketones are absent in HSS, therefore they will have normal anion gap. HSS is most often seen in elderly type 2 diabetes mellitus population. So there are two things operating here, that it is seen in elderly and in type 2 diabetes mellitus population. So there it can cause dehydration, and after dehydration it can also increase cerebral edema, and it can cause neuro symptoms plus. Now we move towards the management of how we will carry out the management of DKA and HSS. Remember, when we have to give, first of all we have to give the IV fluids, because what is there, that it is a high anion gap metabolic acidosis, and therefore we will body have lost a lot of water. So what will happen is that we have to give high flow 0.9% normal saline. Now add dextrose 5% when normal saline, when add 5% dextrose when glucose is less than 200 milligram per deciliter. And remember that when we start the when we starting the early treatment, in that we will give one continuous IV insulin, continuous, and there would be no bolus insulin would be given right now when it is in emergency. And we can switch to bolus when if there is following conditions met, that is the patient is able bolus indication, patient is able to eat, glucose is less than 200 milligram per deciliter, anion gap is less than 12 milli equivalent per liter, serum bicarbonate greater than 15 milli equivalent per liter. That is when we have see what we are focusing on. We are focusing that body has lost its acids, and now it is available. It has a strength to fight the stress, because if it is less than 200, then we can give IV, because now we don't have to micromanage. I mean, an ion gap is less than 12 milli equivalent per liter. Why? See, in an ion, what happens in an ion gap, That means that lots of organic acids are there. So when anion gap reduces to less than 12 milliequivalent, it proves that organic acids have either been flushed out of the body and they are not in any dangerous proportion. So we will give serum bicarbonate, that is greater than 15 milliequivalent per liter. Now for potassium we have to add IV potassium. Is serum potassium is less than 5.2 milliequivalent per liter, and then we hold insulin for serum less than 3.3 milliequivalent per liter. Now bicarbonate would be given for patients whose pH is less than 6.9. Bicarbonate is indicated for pH less than 6.9. Now remember, now we'll do what? Pituitary regulation of hormones. We should remember that pituitary is under the inhibitory effect of the prolactin. So what the prolactin does is prolactin inhibits the GnRH, and that ultimately leads to reduced FSH and LH that manifest in form of infertility, amenorrhea, hot flushes, and decreased bone mineral density. Hypogonadotrophic or hypogonadism is found. That is also known as Kallmann syndrome. That is what's seen in Kallmann syndrome. So what do we see here? Pituitary is under the inhibitory control of the dopamine. One should prolactin, and then what we remember that it is under the inhibitory control of the prolactin. And what happens that dopamine inhibits prolactin release. It has inhibitory control, that is stimulating the D2 will reduce PRL. So remember, dopamine inhibits prolactin release, and that is a vital source of information. And moreover, remember that thyroid releasing hormone from the hypothalamus increases prolactin release. Now there is a concept called acidophils and basophils production of hormones in pituitary. So remember that uh, acidophils are basically GPT. So how will you remember? That is growth hormone and prolactin. Or there's a better mnemonic to remember this. You can remember the acidophils are the general practitioner, GP. Or a better mnemonic can be acidophils, better PG. That is, PG students are very much acidic, they are toxic. So how will you remember that? Prolactin and growth hormone. Now prolactinoma, what happens in this? That amenorrhea, infertility, galactorrhea, hot flashes. What happens is that in prolactin level is increased greater than 20. So we have to rule out 4 conditions, that is TRUD, that is TSH related hypothyroidism. So these are the 4 conditions, that is hypothyroidism, renal failure, urine pregnancy, and antipsychotics. Now if prolactin is greater than PRL concentration comes greater than 200, then take it as pituitary tumor. So what will we do in these conditions? See, if we are witnessing these conditions, that mean there is adenoma formed in pituitary. So what will we do? We will do MRI pituitary. Now in MRI pituitary, what will happen? Microadenoma and macroadenoma. Now if there is microadenoma, it will be controlled medically. If there is macroadenoma, then it will be managed surgically, in which there will be transnasal or transsphenoidal resection. Generally, macroadenoma with greater than 10 millimeter size have pressure effects. And in microadenoma, medically we mean by that if the patient is asymptomatic, if the patient is asymptomatic, then there is no need for treatment. But when it is symptomatic, when the patient is symptomatic, so drug of choice is cabergoline. We have cabergoline. But if it is pregnancy, now in pregnancy the drug of choice becomes bromocriptine. See, in pregnancy the woman is not able to broom the house, so remember that she takes the broom inside her. Now we move on towards the diagnosis of Sheehan syndrome or pituitary apoplexy. It can present as postpartum fatigue and hypoglycemia, constipation, postural hypotension, failure to lactate, and amenorrhea. These all can be manifested, and these all symptoms will encompass to form panhypopituitarism. As you can see here, that here there is empty sella sign. Now, remember that this is a light bulb sign where or let us recapitulate where the all the light bulb sign is seen. And very important is just remember that light bulb sign is also seen in primary polydipsia. It will be really important when we will study ADH and all. One thing that you can remember that suppose polydip, that is a person is taking a holy bath in Ganga, so he's taking a lot of dip inside the water, so everybody is alarmed, so they have all light bulb is switched on, and it is they are being monitored continuously. By that you can remember, because in primary polydipsia you will have to remember that there is light bulb sign seen, and it will be a very important thing there. So it would be good if you learn this information beforehand. Now what we will do, we will see that there is a clinical suspicion. There is a clinical suspicion of acromegaly. Now if you have clinical suspicion of acromegaly, then you will carry out the screening. Now, so screening can be carried out by insulin-like growth factor 1 level. How you will able to find out insulin-like growth factor 1 level screening? Remember that it is the initial investigation of choice. It is the initial investigation of choice. So how will you remember this? I can remember this by that insulin that screening procedures are going to be patient friendly, but at the same time that is highly sensitive. So insulin like growth factor 1 provides us with that choice. Now after that, when IGF-1 is elevated, now elevated IGF-1, we can use OGTT, oral glucose tolerance test. Now in oral glucose we can better say it, but there's a little bit difference here. It is OGST, oral glucose suppression test. So when we administer oral glucose suppression, then there would be reduced growth hormone, or growth hormone will be suppressed. If growth hormone is suppressed, then it is a good sign. If growth hormone is suppressed, that means the body is working physiologically, but the growth hormone is not suppressed, inadequately suppressed, so that means there is increased production of growth hormone. And when there is increased production of growth hormone, it can be either because of pituitary or because of hypothalamus or extra pituitary mass. So if we have to do the localization, for localization we will do MRI. So for localization we will do MRI. Now in MRI of brain, if there is some pituitary mass coming out, then we have to take surgical versus medical management, and if the pituitary masses can be taken out surgically, then we can do it surgically. But if it is unresectable, then we have to resort to radiotherapy. Then we will resort to radiotherapy, octreotide or pegvisomant. Now for remember normal pituitary, we have to evaluate for extra pituitary cause of acromegaly, that can be ectopic growth hormone and growth hormone releasing hormone secreting tumor. So for this we have to do carcinoid. We should suspect carcinoid, and we should carry out. Now we move on to the approach to myopathy. How we will do myopathy? Steroid myopathy. And then we have statin myopathy. And then we have hypothyroidism. That in polymyalgia rheumatica, ESR is raised, but until unless there is myopathy word there, then creatinine kinase will not rise. Except the only exception would be steroids, because steroids are in itself given for reducing the inflammation. So what will the ESR would be increased? This would be increased, but in rest ESR would be normal. But anything that have myopathy written in it, except for steroid, will have creatinine kinase rise. Creatinine kinase rising. So all myopathy increase, but steroid we will leave. Statin myopathy, creatinine kinase will increase. But in polymyalgia rheumatica, it is only pain. So again here, creatinine kinase would remain normal. Now, what are the some other associated symptoms? And one thing that you will have to remember is that statin. Now, statin. One other way to remember statin is stat, because it has static we will get kinase, so kinase would increase, and here there will be pain sensation. Pain would increase, but there will be no weakness. Now we move on to our inflammatory myopathies that we have remembered. See, inflammatory myopathies will see because inflammation, see here, inflammation was going, and since inflammation is happening, ESR would also increase, creatine kinase would also increase. But you further go and divide this into dermatomyopathy, polymyositis, IM and inclusion body myos, immune mediated necrotizing myopathy, antisynthetase syndrome. Now we come on to the inflammatory myopathies. In this you have to remember that in dermatomyositis everything is perimysial, but in polymyositis and immune mediated. Now we move on towards the various inflammatory myopathy. You remember that dermatomyositis have perimysial, where all rest have endomysial. 4+ are found in these dermatomyositis and antisynthetase syndrome. And also rimmed vacuoles. Remember that in IBM, what happens is that endomysial perivascular inflammation is all there, CD8 molecules, plus there is rimmed vacuoles. There are rimmed vacuoles. Now I'm going to discuss the arthritis now. In arthritis, how will you remember that? Often the question would be regarding gout and pseudo gout. And gout, remember that there would be rat bite erosion and Martel G sign, that is pseudo gout. In pseudo gout is seen. So often they are asking that what will appear in apple birefringence color. So remember it by TNM, and that is positive. Now, so there are certain drugs that are used in different in rheumatoid arthritis. See, the drug of choice is methotrexate, and the drug of choice in pregnancy is hydrochloroquine. And in pregnancy, hydrochloroquine reduces the flares. Now, then we have TNF alpha inhibitor, that is etanercept and all those adalimumab, and these are used. But how to remember all this TNF alpha inhibitor? TNF alpha inhibitors is Komarogoli. Now you will have etanercept. Now etanercept, eta, since it is an eta, so it will have two things. It will be against the fusion product of TNF alpha plus IgG Fc, and rest are against TNF alpha. Now IL-1 receptor antagonist, remember IL-1 receptor antagonist, it is against the receptor and not the interleukin. Just remember that. And that is anakinra, CD20 rituximab. Now we move on to vasculitis. In vasculitis, remember granulomas formation. See, all the vasculitis that have granuloma formation, they will have some foreign name associated with it, except for Churg-Strauss, Hinox-Schönlein and Kawasaki. So if you remember the what are ANCA immune complex positive, then you can automatically remember the granulomas one. So let us first learn the what are immune complex related. ANCA immune complex related, HSPC. Now Hinox-Schönlein purpura, SLE and cryoglobulinemia, hepatitis B and C. So you can remember that also. And an additional fact that most common in children is Hinox-Schönlein purpura or Kawasaki disease. Discuss the posterior pituitary. In posterior pituitary, remember that in when discussing the difference between SIADS, central diabetes insipidus, and nephrogenic diabetes insipidus, primary polydipsia, and diabetes mellitus. Now, in SIADS, there would be increased ADS secretion. So, what will it do to urine osmolality? The increased antidiuresis, that means urine osmolality. Urine osmolality would be increased. Plasma osmolality would decrease. Serum osmolality, serum sodium concentration, that would also decrease. Uric acid inversely proportional to ADH, since it has increased ADS secretion. So uric acid would be low. So what is the diagnosis? Diagnosis is SIADH. And what is the management? How will you diagnose SIADH? SIADH can be diagnosed by water loading test. Remember, SIADH is tested by water loading test. Others are tested by water deprivation test. See, when we are testing the central nephro and primary, all these, what we will give? We will give water deprivation test. For all others, we are going to do water deprivation, but for SIADH, we have to do water loading test. So what happens in this? That is central diabetes insipidus. Now, central diabetes insipidus, what happens to the urine osmolality? Urine osmolality will, what will happen? See, in center there is decreased ADH release. Now, when there is decreased ADH release, so there would be diuresis, and there will be diuresis, urine osmolality will decrease, plasma osmolality would increase, serum sodium would increase, uric acid is less, ADH is less, so uric acid would be more. And we know that water deprivation test would be done. Management, what would be the management? Is intranasal desmopressin. Now, desmopressin is also the drug of choice for nocturnal enuresis and bedwetting, hemophilia, and von Willebrand disease. Now, desmopressin is the also used in. Now we come on to the nephrogenic diabetes insipidus. What happens in nephrogenic diabetes insipidus? That is, the ADH is being released, but it is not acting on the kidney. So what will happen? There would be again decreased urine osmolality, plasma osmolality would increase, serum sodium would decrease, uric acid would again increase. And again we will perform water deprivation test. And for this, what we will do? Thiazide. For nephrogenic diabetes insipidus, we will administer thiazide. Thiazide is not administered for central diabetes insipidus. Thiazide administered for nephrogenic diabetes insipidus. It is given in nephrogenic diabetes insipidus. Now, in what happens in primary polydipsia? Remember, in primary polydipsia, serum sodium would be run. One thing that is remaining unchanged is primary polydipsia. And one fact I have been telling you since the beginning is that the MRI would show light bulb sign. If you see light bulb signs, you can jump out to the question that is there is primary polydipsia involved. Now, when there is primary polydipsia, what will happen to the urine osmolality? Urine osmolality would decrease. Plasma osmolality would be again decreasing, but serum sodium would be normal, and uric acid concentration, see uric acid, ADH is being secreted in good amount, so uric acid would decrease or remain normal. Now when we perform water deprivation test, here there would be concentration, there would be osmolality increase. Now we move on to the diabetes mellitus. Then there is the glycosuria glycemic control is the ultimate treatment. Now SIDH. Now how will you remember what are the drugs that are causing SIDH? See, this is the swimming pool where chlorine is being the chlorine is there, so there chloropropamide. Now Christ is going on the bicycle. When Christ is going on the bicycles, cyclophosphamide for cycle. Christ is vincristine, and this is Shashankar Rajput's SSRI. From this you can remember. And another conditions are carbazepine that you remember when compared to carbazepine, and then small cell carcinoma lung, pneumonia, encephalitis. Small cell carcinoma lung. So if somebody asks what will be your approach to patients with coming with diabetes insipidus, see, approach to patient with diabetes insipidus would be, first I will perform, see, you will not going to perform the direct urine osmolality test. First the patient will come, and then you will find evidence for polyuria. First we will see if there is any polyuria. Now after polyuria we have to see that the osmolality of the urine is what, if it is less than 300 milliosmol, that means that there is some problem in concentrating ability. Now after reaching this approach, we will move towards the plasma ADH. Now we will measure the plasma ADH. Now if plasma ADH is high, that means we are dealing with nephrogenic diabetes insipidus, in which thiazides is the drug of choice. When plasma ADH is low, then we are dealing with what? Central diabetes insipidus. Now in central diabetes insipidus, we will have two things that we should be watching over. That is pituitary, or there can be primary polydipsia. So remember, in this what we will do is that in low means less than 1 picogram per ml, high means here 1 picogram per ml. So we will do MRI brain. Now we will do MRI brain. So what will happen? If pituitary bright spot is absent, then we are dealing with diabetes and central diabetes insipidus. Now next we move towards the Cushing syndrome. Now remember, in Cushing syndrome, what will be the blood feature? See, blood feature, you always remember that see, it is immunosuppressive, so definitely would reduce eosinophil lymphocytes and all. But remember that it causes neutrophilia, and it causes neutrophilia. And what are the other features that we will see? See, there you will see that the central body is becoming fatter, that is buffalo hump and all, and the peripheral body is thin, that is, and also the peripheral body bruises easily, thin arms and legs, and the protruding of the abdomen. There would be abdominal stretch marks, and there would be red cheek, pendulous abdomen. Investigation of choice to confirm Cushing syndrome would be low dose dexamethasone. Cortisol. Now what would be the level of the cortisol? In that remains high. So how will you approach a case of Cushing syndrome? Now in Cushing syndrome, when somebody comes, what you will see? First you will see the cortisol level. So definitely cortisol level would be remaining high. So what you give? We give low dose dexamethasone suppression test. When we do give low dose dexamethasone suppression test, we see what is the ACTH level. Now when we give low dose dexamethasone, and if the ACTH reduces. See, if we are getting decreased ACTH, then that is it indicates that the adrenal system is working on its own. That proves that there is adrenal adenoma. Now what happens is there is increased in increased ACTH. Then we have to again make sure that what is the cause, whether it is the central pituitary cause, or is it some carcinoid syndrome occurring somewhere else. So for that, what we will do high dose dexamethasone suppression test. Now after doing high dose dexamethasone suppression test, if the if it shows suppression, if there is suppression, and if there is no suppression, if suppression is there, that means it was central or pituitary Cushing, pituitary hyperactiveness of the pituitary. But when they in periphery and there is no such thing happening, and ACTH remain unchanged, so we should points toward carcinoid syndrome. That is ectopic ACTH is being released, and for that what we do Dotanac PET. This axis, on x-axis it is calcium, on y-axis it is phosphate. So remember, in one there is more of calcium, less of phosphate. On two, there is less of calcium but more of phosphate. And in third, there is increased calcium as well as phosphate. So one represents the primary hyperparathyroidism. Now we will compare different bone mineralization of calcium related diseases under basically four parameters. That is, what would be the calcium level, what would be the phosphate level, what would be the parathyroid hormone level, and what would be alkaline phosphate level. At the outset, I would like to say that alkaline phosphate is like a gold digger. How? That it remains with parathyroid hormone when it increases when parathyroid hormone increases, but when parathyroid hormone decreases, then it will remain normal, except for one or two diseases, one disease. So remember that. What will happen in rickets? In rickets, there is osteomalacia, the decrease of calcium. Phosphate, there is increase of phosphate. Why? Parathyroidism. The parathyroid hormone, what will happen to the parathyroid hormone? It will increase. Alkaline phosphatase would increase. One thing I made the mistake is that in rickets, what is happening, that there is deficiency of vitamin D, and when there is a deficiency of vitamin D, so what will happen? There will be decrease of calcium and there would be decrease of phosphate. Now we move towards primary, secondary hyperparathyroidism. Now we have to learn that in primary, there is low of calcium, there is increase of phosphate. There is increase of calcium, there is a decrease of phosphate, and parathyroid hormone will, if there is blood calcium increase, so parathyroid hormone will decrease, and alkaline phosphate will remain normal or decrease. So here I have committed a major grave mistake, that here the parathyroid hormone will not decrease, because this is primary hyperparathyroidism. That is, there is parathyroid hormone adenoma. When there is adenoma, and also we carry out Sustami B scan. Now in secondary hyperparathyroidism, what is happening? There is CKD. Now when there is CKD, so there will be decrease of calcium, there will be increase of phosphate, and what will happen to parathyroid hormone? Parathyroid hormone would increase and phosphate would increase. That there is increased parathyroid hormone related protein increase. Now parathyroid hormone, when there is increased parathyroid hormone related protein increase, so what will happen? There will be increased of calcium, there will be decrease of phosphate, parathyroid hormone will decrease. What would be alkaline phosphate? When parathyroid hormone decreases, then alkaline phosphates remain normal or decrease depending. Now we move on towards the hypercalcemia. From hypercalcemia or malignancy, we move towards sarcoidosis. Now what happens in sarcoidosis? Sarcoidosis, vitamin D is synthesized. Now when vitamin D is synthesized, so what will happen? There is increase of calcium, there is increase of phosphate, there is decrease of parathyroid hormone, and there is now we have hypoparathyroidism. Now hypoparathyroidism, what will happen here? Calcium will decrease, phosphate would increase, and then parathyroid hormone decrease a lot. Now pseudohypoparathyroidism, remember that it is the end organ resistance. Now we move on to the Paget's disease. Remember Paget's, that in Alp in Hindi, that is very small. Paget's is, that is, we are giving very small things. Page is very small. So alkaline phosphatase. Now alkaline phosphatase would remain normal. Alkaline phosphatase would increase while the rest of the parameters would remain normal. And in osteoporosis, all the parameters are normal. Now how we'll carry out the osteoporosis treatment? Remember, in osteoporosis treatment, we have strong Romeo. Strong Romeo. Now what does the strong Romeo does is strong. It has strontium granulate and romosozumab. So what they do, these both are, what is they are doing? They are increasing osteoclastic as well as osteoblastic activity. That is, they are helping destroying the bones as well as forming the new bones. So they have dual action. Now we move on to stimulating the osteoblast. Now which group of drugs will stimulate the osteoblast? Basically that would be either vitamin D or parathyroid hormone protein. So vitamin D would do it indirectly, but we have to remember that parathyroid hormone would increase, and parathyroid hormone names that are used in this are teriparatide and abaloparatide. Teriparatide and abaloparatide. And now whatever other drugs are remaining, those drugs would inhibit the osteoclast. So in that we will have bisphosphonate. Now what happens in bisphosphonate? That it increases the mineralization. It inhibits the osteoclastic activity. Bisphosphonate inhibits the osteoclastic activity. So side effects of bisphosphonates are esophagitis, osteonecrosis of the jaw, and atypical neck of fracture. Longest acting would be Zolendrate. Annual injection of Zolendrate can be given. Zolendrate side effect is that it can cause renal failure. And we have raloxifene. Now raloxifene side effect is DVT, and also endometrial hyperplasia and carcinoma breast. Denosumab wrangling and negative. Calcitonin refractory to calcium, cinacalcet. So how will you remember? See, we have talked about till PTH 134, that is abaloparatide and teriparatide. These are basically only having osteoblastic activity. Abaloparatide and teriparatide have only osteoblastic activity. Now what happens in bisphosphonates? In bisphosphonates, it is the drug of choice for osteoporosis. So what are the side effects? Now side effects of bisphosphonates are uh, esophagitis, osteonecrosis of jaw, atypical neck of fracture femur. Now we move towards the other, that is serum group of drug. Now in serum we have raloxifene, and then we have indenosumab. In denosumab there is rank ligand inhibition. Now in calcitonin we will have refractory increased calcium, and cinacalcet increases the sensitivity to calcitonin. Now, remember the side effect of raloxifene. Remember, raloxifene is that rail. That is, suppose a pregnant woman travels in a rail for a long time. I mean, that 3 to 5 days in a general class, it would be really hostile type of condition. So, what? How will you remember that raloximab? They are traveling, so there is no leg movement. So if there is no leg movement, then there is chance of DVT. And as she is pregnant and traveling, then her breast would be enlarging, and endometrium would also be enlarging, although it would be due to pregnancy. Now what happens in thyroid hormone synthesis? In thyroid hormone synthesis, iodine is absorbed from the sodium iodide importer, and it is made uh, and it passes the uh, apical membrane through sodium iodide transporter. Now it reaches the basolateral membrane where there is iodine chloride antiport. Now after reaching the basolateral membrane, it undergoes iod organification, that is I minus changes to I2. Meanwhile, the thyroglobulin that is being released from the uh, follicular cells here, it comes out and it binds to iodine. It binds to iodine. So what happens is that thyroglobulin with it. Now what happens is that organification takes place. Now in organification, monoiodotyrosine, diiodotyrosine are formed attached to thyroglobulin. Now when these are attached to monoidoglobulin or diidoglobulin, monoiodotyrosine tyrosine and diiodotyrosine. Now, monoiodotyrosine diiodotyrosine will go under coupling reaction to form T3T4, and thyroglobulin will be attached to it. Now, they undergo endocytosis, and from there, here in the endocytosis, thyroglobulin is released into the blood, and the remaining thyroglobulin is again free to come to inbound thyroid hormone. Now, what does thyroid hormone? Different thyroid hormone parameter occurs in thyroid during pregnancy. So, thyroid hormone during pregnancy. So, what happens is T3 thyroid hormone is thyroid hormone. What happens is that it's in pregnancy, its synthesis increases. Why? Why? Because TSH alpha subunit is similar to beta beta HCG. So what happens is that what happens to free T4? Now what happens to free T4? Now in free T4, remember that increased thyroid hormone synthesis leads to increased thyroid hormone production. Now when there is increased thyroid hormone production, it would be released into the circulation. Now after thyroid free T4, now we move towards total thyroid hormone. Now what happens to total thyroid hormone? In this, there is increased in thyroid hormone synthesis, which leads to lots of thyroid hormone in circulation. But what happens is there is increased in thyroid binding globulin. Increase in thyroid binding globulin results in increased thyroid hormone. Now what happens to TSH? Now in TSH, what happens is that increased thyroid hormone which cause the feedback inhibition. ultimately resulting in low thyroid hormone, low TSH. Now there are certain spotting that you should be able to recognize. Now this is what is known as beefy thyroid, which occurs in Graves' disease. Now here there is scalloping of thyroid gland, resulting in increased thyroid hormone storage. Now here there is called as thyroid acropathy. What happens is here is that there is feathery nature to bone of hand, bone of body. Now here it is pretibial myxedema. Now here is Graves' disease, thyroid ophthalmopathy. So what happens is here is that there is, see, this is Coca-Cola bottle appearance. What do we mean by Coca-Cola bottle appearance? That is the muscle belly would increase, but the tendons would remain as it is. Also, many times the order of involvement of the extraocular muscles is involved. So first, let us see what happens in thyroid ophthalmopathy. In thyroid ophthalmopathy, there is in thyroid ophthalmopathy of Graves' disease. What happens is that there is thyroid proptosis. Now, proptosis, why does it occur? Proptosis because there is increase in muscle mass, and also there is retroorbital muscle fat. It is now the thyroid proptosis will have retroorbital muscle fat. Now, no specs staging is used for its no sign and symptom, only signs symptomatic. Now, P stands for proptosis, E stands for extraocular muscles involvement, C stands for corneal involvement, and S for sight loss. One of the questions are asked is that what are the now how will you carry out the Graves' disease management? Now, Graves' disease management can be carried out by following method. How? See, we can go for radioiodine ablation. That is iodine 131. What we will do in this radioiodine ablation is done, but it is contraindicated in pregnant female and having the thyroid eye diseases, patient suffering from thyroid eye disease. Now here from here move on to the Graves' disease radioiodine. Now we go for the medical management. What we will do medical management. Medical management is done by carbizole. Now carbizole is the drug of choice, but in pregnancy the drug of choice is propylthiouracil. U carbizole or methimazole is given drug with choice, and then we have PTU. Now PTU has propylthiouracil. It is given in pregnancy. It has also the peripheral function of inhibiting conversion of T4 to T3. Now methimazole and carbizole are teratogenic. So what they could cause? They can cause cutis aplasia, and choanal atresia. The side effects of propylthiouracil is agranulocytosis. What is common in between these both drug is that they will have hepatotoxic effect. Now from here we move on to surgical management, where we can do surgical management. Thyroid eye disease. So in thyroid eye disease, what surgical procedure would be used? So they will carry out orbital decompression, because orbital decompression is compression is the one of the complicating feature. or either you will carry out the orbital decompression, or you will carry out the total thyroidectomy. Now from here surgical, we should also know that in what order thyroid eye muscles are involved. See, if you want to see in what order thyroid eye muscles are involved, you can learn it by IMS low. So what will happen? See, for example, this is an eye. So what will happen is that firstly the infiltrating substance would be going towards the bottommost part. Why? Because of gravity. Gravity is the feature. So and then what will happen? Then they will either it can involve this path, or it can go along this path, but the medial side path is chosen, and that is where it goes with the medial rectus, and then reaches the superior rectus, and then it reaches the lateral rectus. That this is the order of the muscles that would be involved in the Graves ophthalmopathy. And after that we have the oblique group of muscles. Now we have different eye signs seen in Graves ophthalmopathy. Now, what are the eye signs? Eye signs in hyperthyroidism. This is still wax sign. Steel wax sign. Now, steel wax sign, that is, this will have a staring look. So, how can you remember that is staring look? They see still wag. The dog wags its tail. Na, it wags its tail, so it kinds of oscillates. But when the tail is not oscillating, still wag. That is, it is still. Then we have the staring look. And then we have Geoffroy sign. Now Geoffroy sign, what is Geoffroy sign? See, when we look upward, then there is creases that are formed in normal individual, but here there is no such crease form. So absence of crease on upward gaze is known as Geoffroy sign. Now this is jelly necks. Now in jelly necks, what happen is there is pigmentation. There is pigmentation on the upper eyelid. So remember, in jelly necks, what happens? There is pigmentation. Now after that we have Hartog sign. Now Hartog sign leads to what? Leads to loss of eyebrows, especially in the lateral part, and this is also seen in thallium poisoning. This is also thallium toxicity. Now this is a Dalrymple sign. That is a retraction of the upper eyelid. Normally when you will see in an individual, this white part of the limbus would not be visible in normal individual, but in Dalrymple sign it is visible. Now after that we will have Von Griffith sign. Now Von Griffith sign, what happens is that there would be lid lag on downward gaze, and this is Mobius sign. How to remember? See, Stilbog, I have told Joffrey. For Joffrey, you can remember that there is a character in Game of Thrones whose name was Joffrey, and he was a king, and there was a very, I mean, living very luxurious life, and therefore he had no worries, and therefore no folding of the forehead. Now we have jelly necks. Now jelly necks is the pigmentation in upper eyelid. In this jelly necks in the upper eyebrow, there is pigmentations in upper eyelid deposition. Jelly. You will often see that cricketers putting jelly. So say jelly, it kinds of appear from far that they have applied jelly. There is something like there is abnormal pigmentation. And also know that jelly is where they why do put up jelly. They put up jelly because they are going to work in a lot of heat environment, and a lot of sun rays would be exposed to it, so they are applying jelly so as to prevent themselves from those sun rays. So simple sun rays, that children are not often not sent outside, because the exposure to sun rays can result in darker pigmentation. So like that you can relate and remember that jelly next in there is pigmentation in the upper eyelid. Now hartog you can split in Hindi, that is हर तरीके से तोड़ देगा. नाउ हर तरीके से तोड़ देगा तो what is इन दी आई that can be pulled off, and there is there's no harm to the eyesight, and that would be eyebrow. From that we move on to the Dalrymple sign. What happens in Dalrymple sign? In Dalrymple sign, you just see that there is a ripple like effect, that is there is eyelid is moving backward, and there is kind of uh, protraction of upper eyelid. And what is Von Griffith? So here Von Griffith, you will have the name van. Now when something like van, then means that it means there is something mobile in it. When something mobile in it, that means that when eyeball will move, then something else will also move, and that is the eyelid. But eyelid will not be able to the eyelid will not be able to catch up, and therefore there would be lead lag leading to von Griffith sign. And then there is Mobius sign. In Mobius sign, the adrenal insufficiency, or we can also call it Addison's disease. Now what happens in adrenal insufficiency or Addison's disease? There are two types: primary and secondary adrenal insufficiency. Now in primary adrenal insufficiency, what is the most common cause of primary and secondary adrenal insufficiency? For primary adrenal insufficiency, remember that autoimmune and TB are the most important cause of primary adrenal insufficiency. Secondary adrenal insufficiency is because of exogenous administration of cortisol, which leads to suppression of the hypothalamic pituitary axis. Now, what would be plasma aldosterone level in all this? Now, plasma aldosterone level in primary adrenal insufficiency would be less in primary and more in secondary. And then we have plasma renin. Now, what happens in plasma renin? In primary adrenal insufficiency, plasma renin is increased, but in secondary adrenal insufficiency, it is normal. Now, what would be the ACTH level? Now, remember, in primary adrenal insufficiency, ACTH would be high, but in secondary, it would be low. So, what would be the manifestation? Now, manifestations are seen in form of hyperpigmentation. Now, what happens here is there is hyperpigmentation. Remember, in primary, there is pigmentation. In secondary, there is no pigmentation. Also remember that in primary, there would be hyperkalemia. Why is it so? Remember, pigmentation is because of the ACTH stimulation. In primary, the ACTH is high. Therefore, it also works from the melanin, that is. So it will have like a melanin-like function. It causes increased in pigmentation. And also because aldosterone level is low. Since aldosterone level is low, then what is happening, that potassium is getting high, whereas sodium would be low. But in secondary, this is because of exogenous cortisol. So there would not be such raised ACTH. In fact, the ACTH would be depressed, and there would be no pigmentation and no hyperkalemia in secondary. Now, how will you approach the diagnosis? That is, what is the investigation of choice? How will you approach? See, whenever patient with primary when adrenal insufficiency would come, then what we will do, we will see the cortisol level, and then the cortisol level would be low. So, in order to understand that whether it is primary or secondary, we will perform cosentropin test. Now, in cosentropin, remember that cosentropin is equal to ACTH. It is like giving ACTH. So, what is their cosentropin? Now, cosentropin, after giving cosentropin, then we will measure the cortisol level. If the cortisol level is low, that means that there is secondary adrenal insufficiency. But if the cortisol level is high, that means I might have said some inaccurate thing in the last parts of this video. So I'm again writing that what will you do then when you have a case of adrenal insufficiency? You will perform a cosentropin test. Cosentropin is similar to ACTH, and when we give cosentropin, then what will happen is that there would be high cortisol level, and when there is high cortisol level, that means that all the excess are normal. But when there is low cortisol, so we have to find out where the problem is. Now, after getting that there is low cortisol, we should estimate the blood value of the ACTH. Now, when there is low ACTH, then we have secondary adrenal insufficiency, whereas in primary ACTH we have when there is high ACTH, then it is primary adrenal insufficiency. Now, how would you approach a case of hypoaldosteronism? Now, in hypoaldosteronism, no, sorry, how will you approach a case of hyperaldosteronism? Now, in hyperaldosteronism, what will happen is that there will be increased aldosterone. Now, increased aldosterone will cause increased sodium and water reabsorption, but on the other hand, it would also lead to potassium excretion. So, and there is also as potassium and H plus follows similar path, so there would be less H plus also. So there will be kind of like metabolic alkalosis. So how we will approach a case of hyperaldosteronism now? Now, in approaching a case of hyperaldosteronism, what we will do is that how would you approach a case of hyperaldosteronism? In hyperaldosteronism, what we'll do that there would be increased aldosterone. Now, increased aldosterone will have what impact? Increased aldosterone will have sodium reabsorption. Now, sodium reabsorption, what we will do? Sodium reabsorption will lead to increase in BP and all, increase in BP and increase in water reabsorption. Also, there would be increased potassium lost as well as H plus lost. So it can lead to hypokalemia, and also as H plus is being lost, so there will be alkalosis. But when we talk about increased water reabsorption here, so there would be no hypervolemia. There would be no hypervolemia. Now, because of low hypervolemia, there would be because why is there is no hypervolemia? Because there is aldosterone escape. What does it do? Aldosterone escape, what it does is that it leads to excretion of water. and therefore euvolumia is maintained. Why does is there reduced? Why is there aldosterone escape? Because of brain natriuretic peptide or atrial natriuretic peptide like factors that causes excretion of. Would you approach a case of hypertension and hyperkalemia? No. Hypertension. See, always see that with hypertension, there are more chances of having hypokalemia. Okay. Why? Because then aldosterone causes a release of potassium out of the body. So, what would be the approach to related to hypertension plus hypokalemia? In all these cases, what we will do? We will measure the renin level as well as aldosterone level. So we will have to remember when there is increased renin and increased aldosterone, that points towards that there is some renin producing tumor. So there is some renin producing tumor, and now when renin is decreased but when there is increased aldosterone production, that means that kidney is functioning autonomously, and there is this would be seen in bilateral adrenal hyperplasia or in Conn's syndrome. Now, when renin and aldosterone both are low, then this can happen when there is when there is persistent hypertension in the body, that is pseudo hyper aldosteronism, in which it is seen in Liddle syndrome. Now, apart from Liddle syndrome, what others we can see? Now, this is first. Now, so we move on to the second. In second, congenital adrenal hyperplasia, or there is Cushing disease. Now we move towards pheochromocytoma. What happens in pheochromocytoma? Remember that it will have most common symptom presentation as paroxysmal headache. Remember that in pheochromocytoma, we do not do FNAC or any kind of biopsy here, because it can be a life-threatening situation. Suppose we are doing FNAC and then there's some spillage, and then it can cause havoc in the whole system. So therefore, we resist from doing FNAC and biopsy. So third, so what we do. So most common symptom is paroxysmal headache. The most common sign is hypertension. So what will happen here is that in pheochromocytoma there will be increased catecholamines in blood. Now the increased catecholamines in blood can be measured by the urine metanephrine. Now there is increased catecholamine, urine metanephrine. Now after that we will look towards doing MRI. Now in MRI we will confirm our suspicion, and it will be light bulb sign. Now after the light bulb sign, what we will do? Scan is used for looking for metastasis. Remember, M is for M. Extra adrenal spread can be seen through Dotanac scan. What is the most common area? That is the paraganglioma, organ of Zuckerkandl, urinary bladder. So there would be in in bladder pheochromocytoma, there would be hypertension where will be micturition. Now remember in extra-adrenal we have this. Now what would be the treatment? Now treatment, you just always remember that first we will give alpha blocker, then we will give beta blocker, and then we will perform the surgery. There is a phenomenon known as vasomotor reversal of Dale. And also remember that urinary bladder, mediastinum, carotid body tumor. Now what we see a light bulb sign here on MRI, and then we see Zellbollen. Zellbollen, what does it mean? Ball of cell in German. So Zellbollen cell is witnessed here. Now remember that it would it follows a rule of 10. In this rule of 10, that it can be bilateral, but this can be bilateral 50% in case of syndromic pheochromocytoma. Extra adrenal would be present in 10% of the population. Malignancy follows 10%, but in cases of familial, there can be 40% association. Now also remember that these paraganglioma tumors